So pulse rate is the number of beats per minute. Adults generally are 60 to 100 beats a minute. And some of the factors that affect pulse rates can include age, physical condition, the degree of exercise just completed, medications or substance abuse, blood loss, stress, and body temperature can all affect pulse rates. We have two types of pulse rates. We have tachycardia and bradycardia. Because remember, the pulse rate, we're actually measuring the beat of the heart. So they're tied in, the heartbeat and pulse rate, we're reading how many times the heart is beating. Tachycardia is a pulse that is more than 100 beats a minute. Tachy, fast, cardia, heart. Bradycardia, on the other hand, is a pulse less than 60 beats a minute. Brady, slow, cardia, heart, slow heart rate. More than 100 or less than 60 may be a critical finding in pulse rates. Normal cardia is a pulse rate between 60 and 100 beats a minute. Tachycardia is a pulse above 100 beats. Bradycardia below 60 beats. And be aware that anyone with a pulse greater than 100 or less than 60 may be a serious patient. And take into the account if the patient is an elite athlete, their resting heart rate may be as slow as 35, 34 beats a minute. And here is a graph that shows ranges of from adult down through newborns for heart rates or pulse rates. You should know the normal ranges for pulse rates in infant and children versus adults. Adults are 60 to 100 and newborns 120 to 160. So double my low end, double the adult low end to get an idea of what the newborn heart rate would be. Now here we have the pulse rate, the pulse rhythm and quality. We have a rhythm. Is it regular or is it irregular? The quality is its force. Is it strong or weak? Pulse quality descriptions and causes. If the pulse is rapid, regular, and full, it could be from exertion, fright, hypertension, or the first part of blood loss. If it's rapid, regular, and thready, meaning it's rapid and regular, but it's a little hard to feel, thready, it could be from shock, late stages of blood loss. If it's slow, the pulse rate is slow, it could be from a head injury, from drug use, poisons, or hypoxia in children. And if there's no pulse, they're in cardiac arrest. Remember, when we say thready, a thready pulse, it means when the pulse feels weak and thin versus a good bounding pulse. Next, we're going to look at respirations. Recall that breathing in is known as inspiration or inhalation, and breathing out is expiration or exhalation. And when assessing respirations, it includes three factors: the rate, which is the number of breaths taken in 1 minute; the rhythm, are they regular or irregular; and the quality, are they shallow respirations, are they labored respirations, or are they noisy respirations? And we're going to take our respiratory rate for 30 seconds and times it by 2. We're going to watch for the rise and fall of the chest. We can put our hand on their abdominal area, but we're watching for the rise and fall of the chest. And in this business, you need to have a watch to be able to time respirations. Now, if you want a watch, if you want a digital watch, that's fine, or one with a sweep second hand, that's fine too. But you got to have a watch. You can't pull your phone out. You start pulling your phone out on a call, patients are going to think that you're texting or taking pictures or doing something that you shouldn't be doing on your cell phone. So in this business, you need a watch. Don't bank on your partner saying, hey, I'll just look at his watch or her watch. What if they're not around you? Sometimes there's a clock in the back of the ambulance. Sometimes it has a second hand, sometimes it doesn't. So break down, go by Walmart, buy yourself a $12, $15 watch and use it. So our respiratory rate for adults, we need the rhythm, the respiratory rates for our adults: normal 12 to 20, rapid or greater than 20 a minute, slow, slower than 12, but are they an elite athlete that can breathe 6 and 8 times a minute? Or absent, not at all. Here we have a graph for respiratory rates. You should know normal respiratory rates versus abnormal respiratory rate ranges. Think of the adult, 12 to 20. If they're 8 or greater than 20, 8 to 24, they're probably within range. But if they start breathing 26, 28, 30, 32 times a minute, there could be some problems. And remember, look at what is going on with the patient and why they may be having increased respiratory rates or decreased respiratory rates. Here we have a picture of regular normal respiratory patterns, 14 to 20 in 1 minute, versus irregular Cheyne-Stokes breathing, where they have 5, 6, 7 breaths, and then they have a period of no breathing, and then they start breathing again. That would be considered irregular respirations versus normal respirations. And these conditions happen in certain medical and trauma problems. If the patient may experience irregular respirations. The respiratory quality. The quality of respirations indicate the character of breathing, whether that it's normal, shallow, labored, or noisy. Shallow breathing occurs when there's only slight air movement in and out of the chest. Labored breathing, on the other hand, occurs when the patients have an increase in the work of breathing, meaning they're having to work to move air in and out. They'll exhibit accessory muscle use, nasal flaring, especially in the pediatrics, and retractions of the intercostal muscles. They may have supraclavicular and suprasternal areas that are using accessory muscles, and you can notice it around the clavicles and the substernal area. Infant and children that are grunting on expiration and sometimes gasp as they labor to breathe. They're grunting as they're exchanging air, trying to get that air out. That is an ominous sign, and a sign that your infant or child is in severe respiratory distress. Don't keep, going, hey, John, come over here, listen to these breath sounds on this kid. No, this kid is circling the drain and he's going to go down quickly. So you need to get him to definitive care. Noisy breathing is obstructed breathing, such as wheezing, stridor, crowing. Wheezing in asthma or COPDers may respond to the prescription of albuterol. So we do carry albuterol on the ambulances to give to patients that are having difficulty breathing. Next, we're going to assess the skin for color, temperature, and condition. Remember, we want to see pink skin. In the dark skin population, we can look at the palms of the hands, the soles of the feet to find pink to check skin color. Pink, it's normal in light skin patients. In dark skin patients, we're going to check eyelids, lips, nail beds, palms of the hands, soles of the feet. Are they pale? Could be from shock, possibly from constricted blood vessels. They could be hypotensive, or it could be from emotional distress. Are they cyanotic? Kind of a blue-gray color. Think back to the child's picture that you saw in an earlier lecture. Cyanosis from hypoxia, which is lack of oxygen from inadequate breathing and inadequate heart function. Or it can be and or inadequate breathing or inadequate heart function. Flushed skin, it can be red or florid from heat exposure, emotional excitement. Jaundice. Jaundice is a yellow coloring of the skin. It's hepatitis of the liver. What we can see there is in dark skin population, actually look at the white of their eyes and it'll have a yellow hue to the white of the eyes. Jaundice, that's from hepatitis of the liver. Mottled, blotchy, blue, red, purple skin, that's we see an end-stage shock, also known as irreversible shock. We want to feel the patient's skin temperature with the back of the hand on the patient's forehead. I know the book shows pulling your glove down partly to touch the back, skin to skin. You have gloves on. If they're hot, warm, hot or cool or cold, you're going to feel it through the glove. So I would not be touching skin to skin, especially with COVID nowadays. So be very cognizant of that. If it's warm, it's normal. If it's hot, it could be from heat exposure. If it's cool, shock. And if it's cold, it could be from cold exposure. So our skin conditions, dry is normal, moist is sweaty, clammy, cool and sweaty, could be shock and anxiety. Cold and dry could be from cold exposure, or hot and dry, or hot and moist can be from heat exposure or fever. Or think about cold, chills, goosebumps, from chills, from cold, from fear. So our skin talks a lot about us. Next, we need to assess the pupils. The pupil is the black center of the eye. When checking the pupils, we're going to assess for three things: pupil size, pupil equality with the other pupil, and reactivity, how the pupils react to light by changing the size of the pupil. With size, are they dilated or constricted? Do they dilate with no light in their eyes and constrict with light? The equality, are they equal? What we're looking for is, if I shine a pin light in the right eye, we want to make sure that the left eye does the same movement and vice versa. And reactivity, do they respond to light in the eye or do they not respond? Are they a fixed pupil? And that can come along with patients that have had glaucoma or had a cataract inserted, can make the pupil look a little bit different and maybe not react the same way. Here on this picture, we have constricted at the top, we have dilated in the middle, and we have unequal pupils in the bottom. We have one large, one small. I'm going to start with the one large, one small. That could be indicative of a head injury, possible stroke. There's X amount of people in the US that it is normal for them to have one large pupil, one small pupil. Dilated pupils, like if we go watch a movie at the theater, our eyes are going to be dilated while we're inside so we can let more light into our pupils. And then constricted. Once you get done at the movie theater, you walk out into the bright light, your eyes will be constricted. Now, there's one other type of pupil condition, and if you happen to have a ballpoint pen sitting in front of you, make sure that the pen part is sticking out and just kind of look at that. That ballpoint, the little ball that rolls around to let the ink out, we also have a pupil condition called pinpoint pupils. Pinpoint pupils, yes, are constricted, but they're constricted more than normal. Constricted pupils, pinpoint pupils, if you have a patient that has pinpoint pupils, that is a sign that is indicative of a narcotic, opioid-based narcotic overdose. Pinpoint pupil, or a pinpoint pupil specific to heroin, codeine, any opiate-based drug will have pinpoint pupils. And after we've assessed our patient, we still have to do a reassessment of our vital signs. We're going to reassess vital signs on the stable patient every 15 minutes. Now, that's to say, if your transport time to the hospital is 5 minutes, you need to take a second set of vital signs before you get into the hospital, because you're supposed to take a reassessment of vital signs on every patient. So it doesn't have to be at 15 minutes. You can take it at 10 minutes, but no more than 15 minutes, because we're looking for any trends between our baseline vital signs and our reassessment of vital signs. We're looking for any trends in the patient. Are they getting better? Are they getting worse? So reassessment of vital signs on the stable patient every 15 minutes. On the unstable patient, we're going to do it every 5 minutes. You don't have to do it right on time, but you don't want to do it later than 5 minutes. So if you do it at 4.5 minutes, that's fine, but just don't let it stretch out over 5 minutes or 15 minutes, depending on the patient. We also have a blood pressure that we can take, or a vital signs known as orthostatic vital signs. This type of vital sign we take on our patient that is having kind of a syncopal episode. Maybe they, feel lightheaded and dizzy. So we want to take orthostatic vital signs. We may not be able to get a good blood pressure to start with, so we're going to take what we call orthostatic vital signs. This is also known as a tilt test. And to take a set of orthostatic vital signs, you're going to place the patient in a supine position on the couch, laying down on the cot, it doesn't matter, but supine, and measure the heart rate and blood pressure. Take pulse, take blood pressure. After you do that, this is the patient that told you they felt a little weak, dizzy. After you lay them supine, measure their heart rate, blood pressure, you're going to help the patient to a standing position. And you're going to wait 2 minutes. So you're going to time 2 minutes. Then you're going to measure the heart rate and the blood pressure while the patient is standing. Then you're going to compare the readings to those taken while the patient was supine. An increase in the heart rate more than 10 to 20 beats a minute, and or a decrease in the blood pressure by 10 to 20 millimeters of mercury, 10 to 20 points, is considered a positive orthostatic test. This indicates inadequate blood volume. A positive orthostatic test indicates inadequate blood volume. Now remember, we're taking our patient from a supine position to a standing position. When you stand this patient up after they've been supine and they say they feel really lightheaded, it's a pretty good symptom of a positive tilt test. If the patient passes out when you stand them up, it's a positive tilt test. Also, if they cannot stand, sit them up and dangle their feet down, and then for 2 minutes, then take the secondary or the second set of vital signs. So this concludes part 4 of 5 parts of patient assessment, covering chapters 11, 12, and 13.